So today I'm talking about the orthopaedic implications of diphosphonate therapy. Diphosphonate really is the same as bisphosphonate, but just one of those Americanisms that we see from time to time. It's based on an article from the JOS 2010, and here we can see one of the classic atypical insufficiency fractures you get on bisphosphonates. Now, when I first looked at this topic, I thought it was a little on the dry side. I thought, is there going to be much to be gained here? But there is some interesting new orthopaedic applications that I think would be relevant and important to know. So hopefully, by the end of the talk, you'll feel a bit more like that. So first, I'm going to talk a little bit about the bone anatomy, mode of action of bisphosphonates, followed by the real orthopaedic applications of reduction risk of fracture, the effect on fracture healing, the novel use of bisphosphonates in joint arthroplasty, and then finally femoral stress fractures. So just briefly, osteoporosis, as we know, is extremely common, affecting up to 30 million in the US. Women greater than 50 have a lifetime risk of hip fracture of 1 in 6. So it's very, very common, and so bisphosphonates are really used to increase bone mineral density and also reduce the fracture risk in these patients. Just some basics on bone anatomy and structure. So obviously we have various cells, osteoblast, osteoclast, which is where bisphosphonates work, and then the bone matrix, which is made up of organic and inorganic components, and these all play a role in the use of bisphosphonates. So what are they? They're an inorganic pyrophosphate compound, which looks like this, and what they've done is they've exchanged the oxygen atom for this carbon atom. And it's really this PCP configuration that has a very high affinity for bone. And the carbon is extremely resistant to heat and enzymatic hydrolysis. So what ends up happening is this allows the bisphosphonate really to be not metabolized at all, and it has a high affinity bone, reaches the bone and stays there for quite a long time. It has various uses, obviously not just in osteoporosis. There's a variety of inherited skeletal disorders in children, osteogenesis imperfecta, fibrous dysplasia being other ones, as well as other metabolic and malignant conditions that we're using for. So there are two generations of bisphosphonates. The first generation are called the simple ones, and the way they work, here's a diagram showing some bone and osteoclast and the red particles of bisphosphonates. So like I said, they've got a high affinity for bone. They bind to those crystals of hydroxyapatite. The osteoclasts take them up and then are metabolized into an analogue that can't be further metabolized. They induce apoptosis. The osteoclast ends up dying, and antigenate would be an example of one of these. The second generation, however, the amino diphosphonates are extremely much more potent, upwards of 10,000 times more potent than the first generation, and they actually inhibit this mevanolate, which is the cholesterol synthesis pathway. Similar mechanism though, inducing apoptosis. And zalendronate, or red class is the name for that you might have seen around, is one of the drugs that's used here. So as I mentioned, it's got a high affinity for bone, and it is this bone affinity that determines how selective the drug is, rather than what's going on inside the cell, mainly renally spread, and it's got a very long half-life of 10 years. Again, just a brief list of all the different ones that are available on the market. So bisphosphonates can be given either orally or intravenously. If they're given orally, only a very small amount is actually absorbed, and there's some various side effects. Commonly, you may have heard of osteoporosis of the jaw, which is extremely rare and very rarely occurs. Another thing that I found of interest was they did a eye crest biopsy on patients that had been taking alendronate for greater than 5 years to see the effect on the microscopic bony architecture. And found evidence of micro damage and matrix failure. They saw that the fibrin, collagen fibres had started debonding, little cracks were forming and they were coalescing into bigger cracks, and this was changing the stress state of bone. So there are people that advocate drug holiday with bisphosphonates. If the bone turnover stops and you're not metabolising it as much, there's probably no reason to continue taking it, and so 5 years is the rough cutoff that people use for that. We all know about DEXA scans, which everyone uses to assess bone mineral density, both at the femoral neck and the lumbar spine. But bone resorption really is a better way of looking at the effect on bone and what's actually happening. So there's a whole bunch of markers which I've never seen used, things like telopeptides and whatnot, which at 3 months after starting bisphosphonates, you can already see an increase in these. and values, whereas bone mineral density takes about 18 months before you can actually see clinical effect. So that's something that may become more relevant in the future. How long do we use them for? Again, I mentioned 5 years. There was a very large study done here, published in JAMA in 2006, of 1,000 postmenopausal women. And they'd previously taken alendronate for 5 years. They were randomised to either continue alendronate or stay on placebo. And they did find there was a residual benefit in bone mineral density and fracture prevention for 5 years in that alendronate group. All right, so now moving on to the orthopaedic implications of fracture and reducing the risk of osteoporotic fracture. So there's an extremely large trial, FIT trial, which was published in the Lancet, a bit of a landmark study, I guess, 2,000 women in the US. They all had low bone mineral density at the femoral neck and either had a vertebral fracture or they didn't. They were then randomised again to alendronate or placebo for 3 years. And what they found was vertebral fracture was reduced by about 50% in the alendronate group, which was quite significant. And then even any clinical fracture also was reduced about 30-odd% there. And there were fewer hip and wrist fractures in alendronate. So this is a very large study, randomised, and pretty good evidence to show that bisphosphonates do have a reduction in fracture risk. With that data, there was various other data, studies that came about. There's a 10-year extension of that, looking at alendronate given again up to 10 years, and that showed an increase in bone mineral density as well. And furthermore, looking at reduction in fractures of about 36%, which is really more pronounced in patients with low bone mineral density. They found people who had normal bone mineral density didn't have a significant reduction in fracture risk. So again, there are good reasons to use these medications in patients with osteoporosis. Furthermore, another study by Lieberman looking again at the use of alendronate over 3 years, finding a statistically significant increase in bone mineral density at the spine and the neck of femur. And then there's been some meta-analysis, again confirming this phenomenon that we've seen here with the low risk of further fracture. So the zoledronic acid is that newer bisphosphonate that I mentioned, and another very important study here of 2,000 patients that all had surgical fixation of a hip fracture. After the hip fracture, they were randomised in a double-blind placebo-controlled trial to either receive a single dose of IV zoledronic acid within 3 months of surgery or placebo, and then to have that yearly after that for a few years. And so here they found there was a 35% reduction in the incidence of a second fracture in the zoledronic acid group. This was to a median follow-up of about 2 years. And then, more interestingly, there was an all-cause mortality reduction of 28% as well in that zoledronic acid group. So clearly, not only are we preventing the risk of further fracture in this study, but we're seeing that, as we know, things like hip fractures have a very high mortality. And so by reducing that fracture risk, we are reducing mortality as well. So pretty powerful numbers here to promote the use of this. But I think this is something that really we haven't adopted into our practice. We treat lots of hip fractures here, and certainly do a lot of bilateral DHSs and other fractures that are common in these patients. So it may be something that would become more common in the future. Now, the next topic of bisphosphonates and fracture healing is very poorly understood. There's been various thoughts about this, concern that they will interfere with fracture healing. There's really little evidence to look at the effect of bisphosphonates on time to union. There's been some animal studies looking at a dog model at zoledronic acid on fracture repair, and they did find, at least in vitro, of a large trabecular volume, increased callus size and strength, but there was some delay in the remodelling as well. So not very well understood. There's other evidence showing that not only, as I mentioned at the start, that osteoclasts are inhibited, but that osteoblasts are actually stimulated. There's a potential anabolic effect on bone for bisphosphonates. BMP2 also being implicated. Again, really poor evidence for this, and it's just something that may in the future come about. So bisphosphonates and joint replacement is something that, again, we don't use here, and I haven't had experience with before, but something that people are experimenting with. And the main premise here is that periarticular bone loss is a problem after joint replacement. The phenomenon of stress shielding as we know, which is really a reduction in bone mineral density due to an alteration of the normal stresses that go through bone when a prosthesis goes in. And so you get osteopenia around the prosthesis, eventually osteolysis. And so the thought was whether starting bisphosphonates could potentially lower this rate of aseptic loosening and periprosthetic fracture, which is one of the problems with joint replacements. One of the studies done here was published in an obscure calcific tissue international journal. Looked at 19 patients after knee replacement and randomised to alendronate and calcium versus just calcium alone. And they did find that in the alendronate group, the distal femoral bone mineral density was maintained over the duration of the study, which was about 1 year, whereas in the calcium-only group, there was significant bone loss. Now, again, this is just observation looking at the bone mineral density, and there was no clinical outcomes of this, but promising nonetheless. A meta-analysis from the JBJS in 2005 looked at 6 randomised controlled trials, both hip and knee replacements, 290 patients, and again they found that there was a difference in the bone mineral density, slightly higher in the group that were on bisphosphonates, and this was more pronounced in cemented arthroplasty as well as total knee replacement. But again, hard to take much out of this as it's really not a clinically relevant outcome. And again, another study from JBJS of 50 patients with cementless total hips, and they were giving, again, a single infusion of zoledronic acid, which is that potent bisphosphonate versus placebo. And they reported that there was a reduction in the acetabular subsidence at 2 years post-op in the zoledronic acid group. But we're talking very, very small numbers, 0.5 millimetre difference between the placebo group, which was apparently statistically significant, but as we know, the accuracy of plain radiographs and the alteration in slight obliquity really probably invalidates a lot of that. And there was a trend of less substance in the femoral component, but probably clutching at hair. So the final thing I wanted to mention was femoral stress fractures or insufficiency fractures. Since about 2005, there's been this association between bisphosphonates and low energy fractures, initially discovered in the subtrochanteric femoral area. And there's been some characteristic findings. We see this cortical beaking here of the lateral femur, which is a periosteal reaction to these abnormal stresses, like I mentioned before, at a microscopic level with what's happening on bisphosphonates. And often patients have a prodromal phase where they actually have pain in that leg, and probably see the GP put down to any number of differential diagnoses, and eventually they have a minimal impact trauma and fracture their femur. So here was one where they showed they had this atypical fracture. It was fixed on the other side. You could already see evidence of this cortical beak. So a couple of case series really is all that's out from an evidence point of view on this information, and looking at 1370 patients, and this was a case series of all low energy subtrochanteric femoral fractures, finding again preceding pain, a stress reaction evident, and the majority of these alendronate patients in this study had this simple transverse subtrochanteric femoral fracture pattern. Furthermore, another journal study here for a case control study of 120 patients, again looking at bisphosphonates in an overall cohort of atypical fractures, and finding that there's a 37% rate of fracture in the bisphosphonate group versus 11% of the control group. Jenny Flynn was a registrar here, I believe, last year, and she published a study in ANZ Journal this year looking at 66 low-energy subtroch and diaphyseal femoral fractures, and they found out of these 66, 30% were atypical, which is actually a lot higher than what's been previously reported. And of these atypical ones, 90% were associated with bisphosphonate use. And these atypical fractures tended to occur in younger, more active people. So certainly there's been an association that's demonstrated in literature, but more than that, it's quite difficult to say. This was the X-rays. They used it again. You can see this cortical beaking on the lateral femur on the contralateral side. So they had that fixed and then came back with another subtroch fracture, which was actually missed. This little sign there, very subtle, but in retrospect was easy to see. So in the future, what does the future to hold in terms of bisphosphonates? There's various other novel medications have been used for osteoporosis. I won't go into the detail here, but lots of other intracellular messengers, rank ligand inhibitors are new ones, and as well as recombinant PTH. But at this stage, they're quite new. There's some promising evidence, but it remains to be seen. All right. That's it.